And we're live.
Hey, thank you. Welcome everyone to our lecture today. I'm very happy to introduce our speaker, Dr. Sherwood Brown. As many of you know, Dr. Brown currently serves as a professor of psychiatry at UT Southwestern Medical Center. He holds two distinguished chairs, one in psychiatric research and one in brain research. He's currently serving as the Vice Chair for Clinical Research, as well as the Chief of the Division of Clinical Neuroscience and the Director of the Psychoneuroendocrine Research Program at UT Southwestern. He earned a PhD in chemistry at TCU prior to earning his MD degree from UT's Medical School in Houston. Very interestingly, I thought, he also completed somewhere along all that work an MBA at UT Dallas. Is that correct?
I'm a comment, yes.
Yeah, so he has an alumnus. Dr. Brown has been a highly active scholar with more than 200 peer-reviewed publications. He's been extremely active at the editorial level across several journals, and he's held numerous awards funding very interesting work, looking at the study of bipolar disorder, some work on substance abuse, and also funding what is the focus of his talk today, some work on asthma in the brain. So we're very happy to have him here, to welcome him today to talk about his work on asthma in the brain. Please help me welcome Dr. Brown.
So I guess if I were going to tie what we do together, we think of it in terms of we study comorbidities of mood disorders. So some of it's related to substance abuse and some medical illness. And the main medical illness we study is asthma, and I'll tell you how we got interested in that illness. And you probably don't require disclosures. I'm used to them, particularly if there's continuing medical education involved or something. But yeah, I am on advisory board for Medscape, which is a WebMD company. But the topic's bipolar disorder, not asthma. So what is asthma, first of all? So it's a condition where there's recurrent attacks of shortness of breath, or dyspnea as we call it, and there's airway inflammation and wheezing due to constriction of the airways. It can have somewhat of a chronic component, which can particularly develop over time, but there's usually some reversibility to the effects, so there is somewhat of an episodic nature of it where it gets worse during periods that would be called an asthma attack. And it's a really common illness. It's one of the more common illnesses of childhood. There's a prevalence of about 7% in kids and about 8% in adults. And as far as sex differences, there's an interesting feature of it. It's overall in the lifespan more common in women than in men, but it starts off in children. Asthma is more common in boys than in girls, but then in adulthood, the onset of asthma is much more common in women, and over time, women actually have a higher prevalence than men. And it's common in all racial and ethnic groups, but it is particularly high in African American population. And it's quite an expensive disorder that's associated with a lot of service utilization. There's about, in the US annually, about 1.6 or 7 million ER visits each year, and they actually account for a quarter of all ER visits total. At Parkland, there were so many that Parkland Hospital that they separated off. They had the area they called the asthma booth, which was a part of the ER just devoted to asthma. They later changed that. I don't think they have that set up at the new hospital. And it's associated with about 500,000 hospitalizations. And actually, mortality from asthma, despite new treatments and things, has actually increased over the last 50 years or so. And the mortality is particularly high in women and in African Americans and in the elderly, which actually by far the highest rates of asthma mortality actually are in the elderly population with asthma. Now I'll give a little bit of a historical perspective. This is a famous quote, which is interesting, and I'll explain it a little bit more in the next slide. But so Sir William Osler is really considered kind of the father of modern medicine, and he was one of the founders of Johns Hopkins Hospital. And back 100 and some years ago, he wrote that all writers agree that there is in a majority of cases of bronchial asthma a strong neurotic element, many regard it as a neurosis, which is a very interesting statement, and I guess reflects the thinking about asthma at the time. I think this slide puts that idea in a little bit more perspective. Back in the 1930s, when they were starting to develop what was called the Holy Seven, or seven disorders that were originally conceptualized as psychosomatic illnesses. Asthma was one of those. But the idea of a psychosomatic illness is not that it's just it's not that it's all in your head by any means. It's just that it's an illness where mood, emotions, and other things can influence the course of it, or there's a strong component of that with the illness, which you could actually apply that to practically actually any medical illness. So how did we get interested in asthma? So I really have not known very many people with asthma, but back in the 1990s, when I was a resident, I was sort of looking for research projects or ideas. I was on the research track. And a faculty member at the time went to an allergist, and they commented about what they felt was the underappreciated effects of corticosteroid medications on the human brain, particularly mood. And that really interested me. The allergist Dave Kahn's still at UT Southwestern, and we still collaborate after all these years. But we originally were interested particularly in the effects of corticosteroids on the hippocampus. It's a way of studying the effects of cortisol on the human hippocampus, and you could use people on prescription corticosteroids that are a lot like cortisol as a model system. And our original, because we were collaborating with an allergist, the original population we used was asthma patients, and that's where the interest began to develop, particularly when we started doing skid interviews on people with asthma, and we saw really extraordinary rates of mood disorders. And I'll mention here in one report we had 25% had current major depressive disorder, and very few, only 25% of those were receiving antidepressants. And that was really a very small study, but there wasn't much literature at the time on asthma and depression and the brain. It was not like heart disease, which was already a really growing field, or diabetes, and the paper was actually cited a lot at the time. Over the years, there have been a lot bigger studies that have looked at this kind of question, large epidemiologic studies, and I'll mention a few of those here. There have been two studies that actually took place in multiple countries. One, the World Mental Health Survey in 17 countries, and they found that there was about the odds ratio was about 1.6 for asthma, for depression. So there was about a 60% increase in depression risk if someone had asthma. Pretty much same was true for anxiety. 1.5 was the odds ratio. And the interesting one was alcohol, which was 1.7. And really, that's still a field that no one's looked at very much, is alcohol use risk in people with asthma. And then there was the World Health Survey, which actually 57 countries, and they had even higher odds ratio of 2.4 for depression, with the highest in South America at 2.9, the lowest in Australia at 1.7 among the continents. And it was interesting that in all continents but Africa, and it was really in the same direction, Africa, it just wasn't quite statistically significant, but the odds ratios were greater for men than for women which what that means really, depression's usually lower prevalence in men, and asthma, as we just talked about, is too, but it does mean that the difference in rates of depression among men with asthma and men without was greater than for women. I'll mention a few other studies. The last two we were involved with, but it was a terrific study done with Israeli military recruits. I don't know why it was limited to men. I believe men and women were both drafted in Israel, but they found, again, an increased risk of any psychiatric disorder as well as mood and anxiety disorders with asthma. And we published a couple of reports in very different populations. So the Trojan paper was with the Cooper Center here in Dallas, which is a sort of a well-personed facility, was very generally often very people with very good access to medical care, high income. It's almost about 95%, I believe, a white population. And we found an odds ratio for depression of 1.4 and anxiety the same at 1.4. So an increased risk of both. And then we looked in the Dallas Heart Study, which was a study done at UT Southwestern. And that's really, the people in it don't necessarily have heart disease. It's an epidemiologic sample of Dallas County, except they oversampled for African Americans to be able to look at heart disease risk factors in that population. And saw much the same thing of an increased risk of any psychiatric disorder as well as depression. And there's also a literature that people with asthma are at higher risk of suicide as well. And the Young paper shows an asthma of suicidal ideation, the risk 1.5, and attempts 1.3. And then there was also a study in an allergy population. Seasonal allergies tend to be common in people with asthma, but it's not the same population. And they saw the same thing for ideation. The suicide attempts, though, did not reach statistical significance. And when somebody has asthma and depression or anxiety, there seem to be adverse consequences for the asthma. There's evidence of poor functioning, lower quality of life. There's pretty strong evidence for an increase in use of service utilization for asthma. ER visits, the odd ratio is 2.1, so they're much greater likelihood of going to the ER. And hospitalization for asthma the odds ratio was 3.7, which is really quite high. They're at a much higher risk for poor medication adherence, odds ratio of 11.4, and medication adherence tends to be poor with asthma, as with many chronic illnesses, and it is thought to be an illness, as it's true again for many common illnesses, that adherence is really, really important for controlling the illness. And there's also some evidence that people with anxiety are what's sometimes called exaggerated perceivers, where they perceive the asthma symptoms in a different way, where they're greater than needed, than might be appropriate, which may explain things like to some extent, the increased risk of ER visits. There's also people can also be the opposite, where they, particularly over time with asthma, don't perceive the symptoms as severe as they are, which can be a risk factor for a bad outcome with asthma if they don't know when to seek care. And there's even evidence that asthma-related death is increased in people with depression. Within one study, a hazard ratio of 2.7. So the take-home would be that when the two occur together, it seems to not be a very good combination for the asthma. Yeah.
I have a question. For the previous slide, is the comparison between the ratios are compared between people with asthma and depression versus people with asthma but without depression?
Exactly.
Okay. Just wanted to know whether it's uniquely asthma or is it combination of the two versus.
It is, yeah. I'll mention an area kind of related to this that's been the focus of some of our research lately, and that's caregivers of kids with asthma. And much of what I said about asthma applies to caregivers of kids with asthma as well, where they're providing the care of children. There was a meta-analysis a few years ago, 25 studies, including one of ours, looking at and found that depression and anxiety were more common in caregivers of asthma than in healthy kids, which is probably no big surprise. Our study found that, and others have found somewhat similar findings too, though, that as with a person with asthma, if the caregiver is depressed or anxious, that they're more likely their child's more likely to use emergent service utilization or unscheduled service utilization, such as unscheduled visits and asthma-related hospitalizations. And I'll have a little bit more to say about caregiver depression in just a minute. Some actually unpublished data we have. So why are the two illnesses linked? And I'm going to probably provide more questions or ideas than answers here. But the first question would be, which causes which, or which came first? And there was a meta-analysis in PLOS ONE a while back that looked at this question. So these were, they took some data from studies that followed people longitudinally over a period of time and that asked questions about asthma and depression. And these were adults. And what they found was that generally, I would say the consensus probably was that the depression predicts the asthma onset rather than the asthma predicting the depression onset, which is a bit surprising. You might conceptualize it as, well, wouldn't you be depressed if you had a really bad illness? It is consistent with some data, though, with other chronic illnesses where they found the same thing in diabetes. They found that being depressed is a risk factor for having a heart attack, for example. So it's really what you might see with a chronic medical condition.
Sherwood, can I ask, do you think that could be mediated by antidepressive medication? That is, having unwanted somatic or brain effects?
You mean somehow bringing out the asthma?
Yes. So I give you serotonin reuptake inhibitors for your depression, and that has a deleterious effect on all.
I'm actually going to have a little bit to say about that in just a minute.
Oh, you're going to talk about it?
I am in a different way. I think probably the answer is no on that. But it's an excellent question. Could the medications for example, things like there are medications, beta blockers and stuff that can bring out asthma type symptoms in people. So it's certainly possible. Our study was much smaller. I just mentioned it because it's another way of thinking about asthma, but generally asthma is a childhood onset illness and depression is an adult onset illness. And when we looked at just a sample of people with both from one of our studies, it was much more common for them to have developed asthma before the depression. So I would say that's just sort of the more intuitive answer. So I guess the question's a little bit ambiguous. If you follow adults longitudinally, the depression seems to occur before the asthma, but nonetheless, probably the vast majority of people with both illnesses had the asthma first.
Can I ask a question?
Yeah, sure.
Was that retrospective? Did you have people?
It was. Ours was. Yeah.
Okay. Because I'm also wondering, I don't know very much about how well how good we are at diagnosing children with depression. So I'm wondering if maybe it's a function of either memory or, our ability to diagnose people.
Absolutely. It's not a perfect science at all.
Yeah.
It's quite possible. It's just, like our design definitely could have missed. I guess just sort of statistically, of course, this could be, again, what you're bringing up, the challenges of diagnosing it in kids, but generally the onset of depression is like in the 30s or something like that, on average. But there are plenty of depressed kids. I mean, as far as mechanisms, I would say the popular mechanism now for everything is probably the immune system and inflammation, and there's certainly a reasonable mechanism linking the two. Some of these, like IL-6 levels, are increased in both the conditions, so it's not completely, it's not impossible that there's something about inflammation or the immune system or neuroinflammation in the brain that's leading to some connection. The other area would be the endocrine system, and there are several bits of information potentially linking them. They're all a bit complex. People with asthma, there are people who are resistant to inhale steroids, and they have this airway resistance to steroids, but it's more in their airways. It's not really thought of necessarily as in their entire body. And then it's been shown numerous studies using, again, blood glucocorticoid receptors that people with depression often show resistance to glucocorticoids, which seems to be part of the illness for a subset. But whether all this adds up and there's glucocorticoid resistance, for example, in the brain that's somehow tied to airway glucocorticoid, no one really knows. There was an interesting study just a few years ago in an animal model where the allergen exposure that induced the airway inflammation, so this is sort of an animal model of asthma, altered gene expression related to stress, including corticotropin releasing hormone, the glucocorticoid receptor, and serotonin function. So this would sort of be the idea that the asthma might cause the depression by biological means. And then the other one, getting back to our original interest, it's always possible that it's related to medications and steroid inhalers, which do have some systemic side effects. Some asthma patients get bursts of corticosteroids as well. Occasionally, someone's on chronic corticosteroid therapy, although that's pretty uncommon now. There's also the potential genetic mechanism, and there are a few things that are somewhat promising, I would say, here. It wasn't real strong, but they looked at this polygenic risk score for depression, and it was a modest predictor of childhood asthma risk. And another study looked at shared genetic influences between asthma and depression, and they did find it between asthma, depression, and neuroticism, but not with anxiety. And twin studies are a little bit mixed, but some evidence that perhaps there's some common genetic underpinnings between the two. And I'll just throw this in here. There's this Flinders line rats that can be used to some extent, although I don't think it's widely used for either, but as somewhat of a model for depression or asthma. And the animals are actually susceptible to both conditions, which is interesting. So I'm going to mention a little bit about treatment. And really the treatment literature is very, very sparse, and it's almost all of it was actually done by our group. But back in the early 2000s, we got a grant actually from the National Institute of Mental Health, which is kind of surprising for an asthma-related grant. And we looked at randomized 90 outpatients with asthma or depression to the SSRI citalopram or placebo for 12 weeks. And what we found was we really didn't see a terribly robust effect on depression. It didn't quite reach statistical significance. If we used a somewhat different outcome of like sustained remission, we did see an antidepressant effect, but then the effect size for antidepressants for depression is pretty small. It's like 0.2 to 0.3, so probably too small of a study. But what we saw that stood out was this decrease in asthma exacerbations or decreased risk with, and there was really significantly fewer people in the antidepressant group required a prednisone burst to control their asthma. And that was really interesting to us. And for a future grant, we dug into the data a little bit more closely, and we found sort of a subset of people within there that had sort of higher levels of depression and really frequent asthma exacerbations. And that was 3 a year. And we did a second study. This grant was funded by the National Heart, Lung, and Blood Institute. And it was originally designed to be a grant focusing on that group, but the reviewers wanted us to not only include that group, but others as well. So ended up with essentially 2 parallel studies of this high severity depression asthma group with lots of asthma exacerbations and people who either didn't have either of those or that met criteria for asthma and depression but didn't meet the severity criteria for either one. And they were randomized to citalopram, which is kind of a newer version of citalopram that had come on the market, and another SSRI. And what we found, you can see there with the asthma control question near, and that's a standard measure. In the low severity group, we didn't really see any improvement with the antidepressant compared to placebo, but in the higher severity group, we saw really quite a bit greater ACQ or improvement in asthma control with citalopram and placebo. And the effect size was something like, I believe, 0.84, so it was really quite large. We once again saw this decrease in asthma exacerbations, so decreased need for prednisone, and I think the effect size there was about a 1. It was quite large. And again, we didn't see a real dramatic effect on depression. It didn't reach statistical significance. It was in line with what you would expect for an SSRI. I think it was 0.2 something was the effect size. So we really largely replicated what we saw before. So we think actually SSRIs may have a positive impact on asthma. The mechanism would be a little unclear. Actually, the serotonin effect would probably not be a good effect on asthma, but there's interest in SSRIs, particularly for their anti-inflammatory effects. They've even looked at it for COVID to some extent. So it may be something through that mechanism. They do decrease IL-6 levels, for example.
Looks like they're more effective for controlling asthma than for controlling depression.
They are. Which we thought, wouldn't it be a good idea to look at people with asthma who weren't depressed? And so far, we've had trouble convincing reviewers that that's possible, that whatever we're seeing, the pulmonologists on that review panel think it has to be secondary to depression. But I don't know. I mean, a 0.2 effect size for 1 or something giving you a 1 effect. I'm not sure. But and then we've also very recently completed. We're working on the manuscript now. A study looking at treating caregiver depression in kids with asthma, and these are unpublished findings. And sort of what we were thinking is summed up a little bit in this paper by Myrna Weissman a little bit. So she published actually several papers. This was the first one. The sort of take-home message of her papers was that if you treat a mother's depression, you're pretty effectively treating the child's depression, which is really quite an interesting finding. And we wondered, could you take that somehow one step further if you treated the caregiver, which in most cases, but not all, is the mother, could you treat a medical illness of a child some way, and would it be, and how might it achieve that effect? So we had, again, a grant from the National Heart, Lung, and Blood Institute, a 2-site study with SUNY Buffalo as the other site. And I gotta say, I'm a little proud. We enrolled, this is not a big population, but we enrolled 205 depressed caregivers of kids with asthma on time in this study. And what we did was we followed them for 12 months, and we followed them every 4 weeks. And most got an antidepressant. It was not designed ever to be a placebo-controlled trial of depression. It was more looking at relationships between their depression and the child's asthma. Most got algorithm-based antidepressant treatment that we did. If they were wanting to go to a doctor or were already going to one, they could remain on what they were treated with, or even if they didn't want to be treated, that was okay as well. We wanted to observe them over time. And what we're hypothesizing was that the caregiver depression would be associated with improvement in the child's asthma, and we thought it might be mediated either through improved medication adherence or by improvement in the child's mood. And what we found was somewhat as expected, that if we looked at the proportion of post-baseline visits in which their depression was in remission, or really the virtual absence of depression, it significantly predicted improvement in the child's asthma control, and in FEV1% predicted, which is a lung function measure, which interestingly is not very strongly related to asthma control, which is more of a symptom-based definition. But we actually saw it predicted both measures, which we were excited about, because also being able to see a change or predicted change in the FEV1% is unusual. Some asthma medications don't do that. And then we looked at mediation models, and I'll explain it as best I can. Our statistician, this is just like last few days things we've done, but as I understand, all of these paths have to be significant, and for medication adherence, they were not. So it didn't appear to be mediated through medication adherence. I will say, I don't think our medication adherence measure was quite the gold standard, and we didn't see a huge change in adherence, although we did see some improvement over time. But then we looked at the child's depression, and we had a different story where the caregiver depression was associated with the child's depression, which then was associated with the asthma control, and really the model was significant. It does appear that the improvement in asthma control that we saw with the improvement in caregiver depression was mediated through improvement in the child's mood, which was exciting to us. It was somewhat like what Weissman found as far as depression and improving the child's depression.
Way in there, I think it looks to me like a partial mediation effect,
I was going to
not
say
a full
the same.
mediation.
Yeah, because the C prime
The
is still
direct path is still significant.
Okay.
the C prime, that is p-value of 0.001. If that was not significant, then that would mean that the caregiver depression, child depression, is completely mediating the relationship. This seems more like a partial mediation, and therefore I think the moderation analysis would be of really great interest for this.
Okay. Now I'll turn to more cognition in the brain and asthma. I guess about 8 years ago, we used, again, the Cooper Center here at Dallas data set. We looked in 1,380 patients there at the Cooper Center, and they have MoCA scores on people over 55. And we found that the group with asthma, and this is a very healthy population, by the way, at the Cooper Center, and their asthma, for the most part, seemed to be quite mild, but it was interesting, based on their MoCA scores, they were at a 78% increased risk of mild cognitive impairment on the MoCA, which was a little bit surprising to us that they would, particularly with such mild asthma, for the most part, that they would have such a difference in cognition. And since that time, people have looked at this quite a bit. There was this review by Irani and a meta-analysis of studies. They found that asthma was associated with all sorts of cognitive deficits, global and impairment, academic achievement, executive functioning, as well as smaller effects on learning and memory and visual, spatial functioning, and that the severity of asthma did moderate the effects. And it was greatest in younger people, males, low socioeconomic status, and in minority groups. So it's really, the difference was between asthma and the controls was greatest in sort of what would be considered a high-risk group for poor outcomes with asthma, which is probably worth thinking about, particularly in terms of medication adherence and things that cognition might be involved with. And there were also a couple of studies out of Taiwan suggesting that asthma was a risk factor for dementia, and they were published about the same time. They seem to be independent studies, separate papers by different groups, but they both used, it's a terrific database, but Taiwan for public health database of patients, so the sample size were large. They had kind of similar findings. It would be great to see this replicated in a different database, whether there actually is an increased risk of dementia or not with asthma. And now I'll talk about a few neuroimaging studies. I would say the literature is kind of fragmented and a bit confusing, but hopefully I'll tell about a study we're doing with Dr. Park in a minute, and Dr. Ritz at SMU. So the first study I can find in really neuroimaging and asthma was this one in contemporary clinical trials, and they were people enrolled in a trial that they thought might have potential neurotoxicity, and this was just sort of really clinical diagnosis that there were a lot of MRI abnormalities in the people with asthma, including hyperintensities, and only 38% had normal MRIs, which seems a little odd for such a young group, but again, there's no control group, so it's a little hard to know what to make of this. We published a paper within the Dallas Heart Study a few years ago where we looked at asthma patients compared to people without asthma in the Dallas Heart Study, and we did find that they had smaller hippocampal volumes. It wasn't a real large difference. It was interesting. The difference was almost exclusively in men, though, where they had about a 3% smaller volume, and women only about a 0.6% smaller hippocampal volume. And then some of the,
Yeah, the previous finding is so fascinating, and given that you told us about the age of onset for men and women being so different, that men have earlier age of onset, usually in childhood, and women have a later age of onset, I was wondering whether in the subgroup analysis, and given that it's a large participant, it's possible to look at mediation effect or moderation effect of age of
duration
onset.
Of illness.
Or age of onset.
It's a fantastic idea. Unfortunately, it's really a great idea. The Dallas Heart Study doesn't have that much medical illness data, really. Yeah, all they really have is like a self-report of asthma, which, by the way, that's been studied, and it's pretty good, a self-report of asthma. They've looked at it, compared it to it's reasonable, but they don't have like the age of onset or no, they don't. It'd be great though. This is a study Thomas Ritz at SMU did. We were authors on it too. So they looked at subcortical gray matter reduction in asthma. What they found was that asthma control and what they called asthma catastrophizing, or it's really a sort of a response to asthma on a scale, was negatively associated with putamen gray matter volume and asthma duration, and catastrophizing with palladium volume. So then I'll mention this study that had a little bit different findings. So this was one looking at structural changes in asthma. Again, small sample size of only 14 asthma controls, but they actually found increased gray matter volume. It was a somewhat different brain region, and that the finding was associated with longer asthma duration. And there was a resting state study with findings. They were sort of focusing on the default mode network, and they did find differences within the default mode network, and they found increased connectivity between default mode network and the salience network. And they looked at altered degree of centrality, which I must confess, you probably know more about it than I do. And it correlated with the degree of airway obstruction. And then they looked at granular causality strengths, and it correlated with depression severity. So I guess what I would take home from this one a little bit is they did find some differences in people with asthma that were sort of perhaps consistent with what some of the things you might find in a mood disorder population, which is interesting. And then Ritz did publish a task-based fMRI study. So they young population, I think a lot were students, 26 years was the average. And the paradigm was to view distressing film clips, neutral film clips, or a crosshair image, or the baseline control, and they looked at the bowl signal. And not really surprisingly, airway resistance increased when viewing the distressing film clips, and other people have shown this. Our collaborators in Buffalo have, over the years, used a model in kids with asthma where they show it's getting very dated now though, but the death scene in ET, and they can see airway resistance increase when the kids with asthma view it, but you don't see that in kids without asthma. And they found, anyway, there was increased activation in several brain regions, the superior frontal gyrus and some others. And the airway resistance correlated with activation in the anterior middle cingulate. So again, kind of some things that are in brain regions related to mood and emotions.
Can I just say, I think there's a problem, not just for this study, but generally for this thing. If you're getting individual differences in something like oxygen intake into the, and presumably CO2 exhalation, because of increased airway resistance, you cannot be confident that any of those fold changes are actually neural in origin. They could potentially have a vascular component. You know, you can boost fold signal enormously just by asking people to hold their breaths. So I was just thinking that in asthma generally, how you're going to controlling for that could be quite difficult to do.
It's very hard because, yeah, you can't really ethically put controls in a condition.
I don't know how you do
it. So it'd be very hard. No, it's something I've thought about, that's really a limitation of functional studies in asthma.
Yeah.
But I think another limitation is that it doesn't have a control group. It only has, from what I understand, people with asthma.
Yeah,
so we don't know these changes.
It was very much a correlational study.
Because it could be like even anyone seeing distressing film clips, because it distresses us. Maybe this is a response, and the more distressed you feel, the more airway resistance you have. So it would be really interesting to follow this study.
I know in kids they didn't see it with distressing focus, but I don't know if I'm not sure anyone's looked at it in adult control. If they have, it would be Thomas Ritz probably who's done it. And then I'll just mention briefly this paper that it's so new, it's just a preprint. I just ran across it just the other day trying to prepare this talk, but they examined diffusion-weighted magnetic resonance imaging, and then they looked at blood-based markers of Alzheimer's disease. They had, oh, by the way, there's a typo there. It was not 11 people with asthma. It was probably 110 or something. Yeah, it was a large comparable in a kind of a young population, though, the mean age of around 40. And they did find, they said, differences in several of the DMRI metrics that they said were indicative of neuroinflammation and neurodegeneration. And they did find that they were associated with two of the markers, but not with the p-tau 181, which they said would be the marker most associated with Alzheimer's. So I would say it's kind of mixed results a little bit there, but and they did find that the asthma severity was associated with the neuroimaging outcomes and with the slower processing speed that they observed. So I know we're a little short on time now. I will say a little about what we're currently doing. And so we have in this area the Dallas ABC study, or Asthma, Brain, and Cognition study, which is an NHL-funded R01. And the hypothesis is that people with asthma will have accelerated brain aging. And this sort of goes over the aims, but basically it's a study where we're looking at several cognitive outcomes. We're looking at brain structure, chemistry with magnetic resonance spectroscopy, and resting state, etc. And we're looking at relationships between things like cognition and the biomarkers and the neuroimaging outcomes. And Thomas Ritz at SMU is the contact PI on it. I'm the MPI, and Denise Parks, a very important part of the study as well. The goal is to enroll 126 people, 40 to 69 years old, and, with asthma, and 66 controls. Enrollment's not bad, but it's been slow. I don't think we're gonna, unless we got a couple of no-cost extensions, meet the enrollment goal. But it's been busy though, and we are continuing to enroll people, and that this sort of summarizes the processing speed, things we're looking at, some of the fMRI outcomes as well, DTI, etc. And so conclusions, I would say asthma has long been appreciated as an illness with potential connections to the brain. However, really hasn't been researched much, except in the last, say, 10 to 20 years. Mood disorders are really common. It looks like treatment may have a positive effect. And also cognition seems to be poor, and there seem to be brain-related changes in people with asthma. And I want to thank our collaborators on these studies. And of course, I want to thank my research group, and I've got to thank our funding. I couldn't do it without them. So with that, I'll open it up for any additional questions.
Great. Can I just go there, please?
I had this is a fantastic talk, and I have a son who has an asthma, so I was even more vested into it. I have a son who has an asthma, so I was more vested into it. The part of the reason for asthma, for his case, he was diagnosed at 1.5, is because of severe allergies. And after moving to Dallas, I've seen that many of my friends and relatives have developed allergies, and we're given prednisone before we go out to do sports or something like that. And it seems like a developmental thing and regional thing. I was wondering in your multi-site study, because I'm also from, Syracuse, New York, and I never had any, allergic symptoms. I was wondering if there is any site difference between the prevalence of asthma or allergy relationships between your SUNY site and Dallas, and whether there could be interesting moderation analysis to look at of like the location or even the relationship between precedent of allergies and asthma.
Well, just for site differences, statistician did put in site into the analysis, but that's a good question. I don't know if we've even discussed it. There seems to be plenty of asthma in both locations, but they are very different.
Different allergy.
And asthma does have very different prevalence in different areas. Actually, for reasons that are not clear to me, Puerto Rico has some of the highest rates of asthma in the world. I don't know that I would intuitively think that either. No, that's a good question. I hadn't really, we haven't really looked at like differences in asthma between the sites. But yeah, there are different allergens and all in different sites, which I guess you made me think of another topic peripherally related to this that we published one paper on, but it's very interesting. There was even an article in the Atlantic on this topic once, but pollen counts, of all things, have been shown in numerous studies to be associated with, I don't know about depression, but with suicide. And they've shown it in several different countries. Our contribution to the literature was looking at not suicide completions, but a study looking at suicide attempts and using the Parkland database over many years and all that. And it was, it's interesting to think about pollen potentially altering, it's probably through immune responses that could lead to depression or other types of illnesses.
Can I ask, the most recent study you're doing, it's a kind of two-part question. Firstly, what do you mean, or you and your colleagues mean, by brain aging? Because that's a somewhat controversial concept. And second, what is the hypothesis that would link chronic asthma to brain aging?
I don't remember who came up with brain aging for the study, the term.
It's a very emotive term
in
cognitive aging literature.
Okay. I can tell you our thinking, and we're going to look at some of these, but the thinking of why the brains with people with asthma as they get older would be different. The ideas were immune, and we do look at some inflammatory biomarkers and other things like that. We are looking at medication. We look at asthma characteristics, age of onset, and asthma severity, frequency of exacerbations, and things like that. The general idea was that one or more or many of these factors would lead to greater brain changes over time in people with asthma than people without asthma.
So, I think you mentioned, just to remind me, if you look at, say, 70-year-old folks with or without asthma, do you see, for example, exaggerated cortical thinning in people who've suffered from asthma throughout their lives compared to controls?
Really don't have the data to look at that. Actually, our study is through 69, so we won't have.
Well, I just gave that as an arbitrary.
Yeah, we don't really, we haven't looked at the data really enough to have an answer, and nobody else has done a neuroimaging study in older people with asthma.
Really?
actually had a somewhat related question. I was wondering if, and I don't know the asthma aging literature, but can you not look at this as a model of like low-grade hypoxia and the effects of that over time or is that a wrong assumption about what asthma is doing, or is that only for some asthmatics? That's what I was kind of thinking in terms of underlying mechanisms of aging.
That's a really good question too. That's one that can generate controversy if you start using it to an allergist or pulmonologist. But yeah, people in their research studies, in their papers, always mention the possibility of hypoxia. But I guess the idea is that true hypoxia is uncommon in people with asthma. They're having very severe exacerbations. So it's not an illness like, say, COPD, where they actually do have chronic low-grade hypoxia. So probably looking for those effects would be more in the brain, would probably be COPD.
But it would be interesting, though, that could be a literature to be established that shows lots of maybe white matter changes, for instance, say, that would kind of track that direction. If you were looking for kind of an underlying mechanism too.
I do want to add one more thing I didn't put on the slide, I just forgot to mention, but we were very fortunate due to the large amounts of money coming to the National Institute on Aging that they offered they offered supplements to people with grants funded through other institutes. So we did get a supplement through that mechanism, and we are doing, by the way, PET imaging as well in some of these patients.
Amber, you?
Yeah. So I think in one of the earlier slides, you pointed out that I think SES was highly associated with asthma prevalence.
It is.
And with aging as well, I mean, those kind of environmental factors all kind of feed into the same thing, where with low SES, you have maybe poor nutrition and access to healthcare and so on, and live in poorer environments, maybe with more pollution or whatever it might be, which would increase prevalence of asthma and then also be related to aging as well. And so there could be a compound there of those environmental factors which would increase both asthma and not negative, but unhealthy type of aging.
Oh, no, it definitely could be. It could be.
And I was going to raise the same point and also ask about adverse childhood experiences, if you think that that is a factor that's influencing both depression and asthma.
It definitely could. I'm trying to remember in this study, we usually, in all our studies these days, assess it. I think we are looking at it in this study. But yeah, I know it could.
I'm going to speak to the ceiling.
Okay.
Assuming that Camilla, are there any questions on the chat?
We do. We have one question. The question is, have you noted any gender differences in the corticosteroid treatments?
Yes, we actually did find one difference in a study. So we did a study in healthy controls that was published a few years ago, and we gave them cortisol for 2.5 days, and then we looked at their hippocampus. And what was interesting was we could see, which wasn't surprising, one dose will do this, but we could see a decline in declarative memory, and we had a placebo condition. It was a crossover design. And we saw, but what was probably more interesting was we did see a decrease in hippocampal volume that was significant with that short of an exposure. Of course, it was reversible. I think it was about let's say a 2.7% or something decrease. That may have been the amount in women, but anyway, it may have been more like 1.7 overall. But yeah, we saw a greater decrease in women in hippocampal volume than in men. We did see that in that study.
So if it's reversible, what's the mechanism that's giving rise to the hippocampal volume changes with cortisol?
It's somewhat unclear. If you take the preclinical literature, they usually relate it to glutamate toxicity and so on. And they usually talk about dendritic shrinkage. So, I mean, that would be one possibility, and that's a generally reversible process. So that would probably be the most obvious explanation. The more, I would say, boring explanation that's potentially possible too is just, it could be something just different about really water content and all that, because I mean, they use dexamethasone for that purpose.
Yeah, to reduce edema, in fact.
Yeah.
Yeah.
And either of those would be reversible pretty quickly.
Yeah.
Oh, yeah.
Yeah, it's actually, well, first of all, thank you. It's not really a question, it's more of a comment. I appreciate the bit that you had about caretakers and their relationship with who they care for. I feel like that's something that's definitely worth looking into, especially since, you know, working with these people, especially in like more extreme medical situations. Caretaking is kind of an environmental factor that does have an effect and bring about comorbidities in these people that are actually caring for others. So I don't see that relationship explored a lot, so I appreciate that you included that.
Oh, thank you. And, you know, one of our collaborators, Betsy Wood, is very much a sort of expert on sort of child-parent interactions. So we actually going to look at some interesting things involving that as part of the study, as well as secondary analogy.
So according to the SSRI studies, it seems as though increased serotonergic activity reduces asthma-related events. Do you know which brain areas or circuits are responsible for that?
No, we don't. And we don't know necessarily even that it's related to its serotonergic effects. It could be some other effect of the SSRI, of the, like I mentioned, any inflammatory effects. Or it could be, as the skeptics believe, that it's all related to improvement in that little improvement in depression, which is possible too.
To I suppose, add a plausible mechanism in the skeptic camp.
Yeah.
Not that I am in the skeptic camp. With depression and anxiety being strongly comorbid, and high levels of anxiety in individuals with asthma can certainly provoke asthma attacks. It could be a simple mediation through that. By reduction in anxiety symptoms, you're reducing a possible triggering event for an asthma attack, which seems plausible, but the effect sizes do suggest something else is going on. I tend to agree.
Yeah, absolutely. Yeah, it's possible a little effect or a little improvement in depression leads to a big improvement in asthma. It could.
Or response to asthma.
Yeah.
Let's put it that way.
Yeah.
Questions? Great, thank you.
Okay, well, thanks very
Very
much.
interesting discussion.
I was but it's what is love with something. Because it's
I was trying to.
because it sounds, you know.